Welcome everybody to this lecture in our second Grand Round series in cardiovascular imaging, organized by the Department of Radiology and Cardiology of the University Hospital of Zurich. It is my great pleasure to welcome today Professor Antonio Esposito from Milan, from one of the many hospitals in Milan. I have to confess that for me, it's not clear how many hospitals and universities there are. He will talk today about a topic which I think is very important. And he worked a lot on this topic in recent years, and I always was a little bit jealous when looking at the Medline, seeing all these fantastic publications. And I think this is a topic that will follow us, or we will have to follow also in the near future, particularly with photo, which will be helpful in this regard. So thank you for joining our webinar. The word is yours.
Thank you very much, Hatem. Thank you for the invitation. It is a really great pleasure. So I will start immediately to have the time also for the discussion. I hope that everything is okay with the presentation. It's impossible to me to go to the second slide. Why? Okay, it works. Okay, speaking about the myocardial MRI, we know that in cardiac MRI, the cardiac MRI became really very important, the assessment of patient with cardiac disease for several reasons, but mainly for the myocardial characterization. Myocardial characterization, which is based on late gadolinium enhancement, also more recently on mapping that allows a sort of pixel-wise myocardial characterization. And if we want to subclassify the different techniques for myocardial characterization that we have in CMR, we can say that we have techniques that are aim as to make a sort of extracellular fibrosis imaging with a qualitative and a quantitative approach, so the LG and the ECB mapping. We have techniques that we can call edema imaging, like tissue-weighted images and tissue mapping. We have technique for the assessment of fat and for a lot of information. So, for example, the T1 mapping that has an hybrid results and an hybrid information. And finally, we can classify the tissue-weighted map, the tissue style mapping, as an IO imaging. The most important about one of the most important, know that it is really fundamental for the differential diagnosis of different cardiac disease in our clinical routine, from ischemic to non-ischemic cardiomyopathies, and for the differential diagnosis, because essentially the transmural and segmental involvement of the left ventricular wall or of the right ventricular wall, it is related to the pathophysiological mechanism at the origin of the myocardial damage and fibrosis replacement. And the late gadolinium enhancement, like the late iodine enhancement, essentially it is based on the different kinetic of the contrast media in an healthy myocardium or in an infarcted or injured myocardium. You can see that the kinetic is completely different. And so if we go to acquire our images at this point, after 7-10 minutes, we have that the concentration of the contrast media in the scarred myocardium, it is significantly higher than the concentration of the healthy myocardium. This is the basis. And we know that in CMR we can obtain a very high contrast ratio between the scar or the acutely injured myocardium and the normal myocardium, because we have the capability to suppress the signal of the normal myocardium with a low concentration of gadolinium. And we have to know that the kinetic of the iodine contrast media is exactly the same of the kinetic of the gadolinium chelates. This was definitely demonstrated also for the myocardium in this interesting and accurate paper made on rabbits with an ischemia perfusion model, in which they demonstrated that the kinetic is exactly the same in the normal and in the infarcted myocardium. And so, on this basis, if we go to acquire the images and 10 minutes in the clinical setting, we can obtain the late enhancement also CT. Why the late enhancement CT? For different reasons mainly of availability, acquisition time, combination with the coronary artery evaluation, which are the disadvantages, obviously, compared with the CMR. We already introduced this. The disadvantage is the reduced contrast to noise ratio, because we does not have the capability, at least up to now, to suppress the signal of the normal myocardium. So the CMR has a higher contrast resolution that allows a better myocardial tissue characterization in LG, and moreover, has a higher range of techniques. So it is a completely multiparametric techniques, but we are arriving also with CT to be completely multiparametric. Why we have to perform the late enhancement in CT, for example, in patients with different cardiac devices, to be very important, because we know that independently by the safety point of view, that can be also resolved. We have some problem of image quality in patients with ICD and pacemaker, and moreover, it is more complicated to perform the CMR than the CT. Obviously, claustrophobic patients, and our first application here in San Raffaele Hospital was in patients with ICD, because it was particularly in patients with recurrent ventricular tachycardia that have to undergo to a transcatheter ablation. And you know that these patients, in most of cases, already have an ICD, and so it is really more easy and faster, and also instead of MRI, because you can see that with the CT, only a very small part of the posterior septum became accessible at the late enhancement. After this first application in 2015,
when I drink coffee or clean my teeth.
Okay. After this first application in 2015,
myocardial delayed enhancement CT for the evaluation of heart failure.
Sorry, I'm not sure to understand the question. If it is
I think we will postpone the questions to the end of your presentation.
Okay.
Sorry for this.
Okay. No problem. No problem.
I muted the other voice, so now it should be fine, and we have the questions.
Okay. Thank you very much. So after this first application in patients with ICD, in order to characterize the substrate of ventricular tachycardia, a lot of people arrives in the literature as Adam has introduced the assessment of patient in the emergency department for the differential diagnosis in patient with heart failure and related cardiomyopathies, and patient with sarcoidosis, and patient with hypertrophic cardiomyopathies, and patient with myocardial infarction, and so on. What it is important is to have the capability to obtain a good image quality, and so a good accuracy in the assessment of the late enhancement in CT. And essentially, it is based on different aspects. First of all, it is based on the scanner that it is available, on the parameters of scanning, KBP and mass, on the characteristics of the patient, so the BMI is very important, the contrast media acquisition timing, it is important, and also the reconstruction and the scar etiology. So all these are determinants of the contrast to noise relation, signal to noise relation in the late enhancement based on CT. And moreover, it is also important the reader experience, because it is then the late enhancement in CMR, at least at the moment, but probably we will have better image quality in the future. First of all, the contrast media administration. The contrast media administration, this paper has compared different combination. The arterial phase, a single bolus for the arterial phase, followed by a second bolus to increase the concentration of the contrast media with an early administration, or a single bolus with a slow and long administration that arrives up to 10-15 minutes, so up to the time of the late enhancement. Essentially, this last combination is not used, because it was demonstrated that it is less efficient, in particular in patients with subendocardial scars. You can see that you have, with this kind of approach, a high concentration of the contrast media in the left ventricular wall, also at the moment of the equilibrium, so at the moment of the late enhancement scan. And so, for example, you can see that here we can see very well the adipose metaplasia, but we cannot recognize the scar, because you don't have sufficient contrast resolution compared with the blood to be used. A single approach with a single infusion, a single bolus with a single infusion during the angiographic scan, or the angiographic scan for overdose of the contrast media for the late enhancement. essentially, the choice between these two approaches depends also by the amount of the contrast media that you want to give to the patient, and depends a lot by the detectors and by the level of interactive reconstruction that it is available. But we will see about this. The contrast media concentration. Obviously, higher is the contrast media that we provide to the patient, higher is the quality of the late enhancement in CT. Which is the bad compromise of the quality of the late enhancement. Essentially, the better compromise is, first of all, to works with as low as possible KVP, and also these parameters depends by the scanner that it is available, but depends also by the patient that we have in front of us. Concentration at least 370 or 400. About the amount of contrast media in the clinical practice to have a very good image quality in late enhancement, it is suggested essentially to use of other kind of parenchyma around the body. For example, essentially to use the same approach that we use in the liver. You know that for the imaging of the liver in CT, essentially we are around a dose of 0.6, 0.7 milligrams of iodine per kilogram of weight, and this is the same amount of contrast media that we have to use for the characterization of the myocardium. So essentially, you can use this kind of formula to calculate the total dose of contrast media that you have to provide to your patient to obtain the maximum quality of late enhancement. Balance is what we can use in human patient. Concentration of contrast media in grams multiplied for 0.6 or 0.7. Another aspects is the delay of the scan. Essentially, it is suggested to make the scan essentially with the same delay that we use in CMR, or if in CMR, usually we are between 7 and 15 minutes after the administration of the contrast media. In CT, it is important to stay between 7 and 10, more closer to 7, and because after the 10 minutes, you can decrease the contrast to noise ratio, and over 3 minutes, but it is also better than 5 minutes. And it was demonstrated in this. Introduced the problem of the KVP. Obviously, reducing the KVP, we're going closer to the KH of the iodine, and it is very important, because going closer to the KH of the iodine contrast media, we can divide it on our images from the iodine contrast media. But we have to consider also that the correct choice between 70 kV, 80 kVp, 100 kVp, 120 kVp depends by the single patients. What we use in our clinical setting is to stay at 70 or 80 kVp in patients that have a BMI that it is lower than 30, and to use 100 kVp in patients with a BMI that it is higher than 30. But as I already said, of the detectors, you can see that stay at low as possible KVP. It is very important, because it was demonstrated that, for example, in this study on porcine model, you can see that the conspicuity and the enhancement with the late gadolinium enhancement is significantly higher for the KVP scan, 80 KVP scan compared with 100 and 120, and obviously also the contrast to noise ratio, it is significantly high. To use a low KVP approach, but with the high mass, because also a lot of photon or low energy, because obviously in this way you can counterbalance the noise related to the low energy of the beam that you have used. We have already said that it is also very important the patient that we have in front of us. Obviously, the quality is strongly impacted by the BMI of the patient. You can see two different patients. As I said before, we use 100 kVp in patients with BMI that it is higher than 30T, and you can see the difference in the image quality for this subendocardial scar in a lean patient compared with a slightly obese patient. So obviously, in particular, if you are starting to perform late enhancement in CT and you don't have a large experience, it is important to start with the patient. It is very difficult to have good image quality in patients that are larger than this. Obviously, the reconstruction are also important. We use the same reconstruction planes that usually are used in CMR, but what it is important is also to have some reconstruction with an higher thickness of the slice in order to reduce the noise of the image, going to the same thickness that we usually use in CMR, and also really have a strong impact in this setting on image quality and also in the diagnostic accuracy, the availability of the newest model-based or AI-based iterative reconstruction that increase the image quality and increase the conspicuity and the sensitivity in the detection of the scar. You can see the same patient with the reconstruction based on filtered web projection, highly iterative reconstruction, and model-based. Widely demonstrated that the use of the newest iterative algorithm allows to increase everything, both the signal to noise ratio, the contrast ratio, and obviously reducing the image noise. An impact it is also related to the etiology of the scar. Obviously, we know very well that a large post-ischemic, post-infarct scar is a scar that has a dense composition. So it is mainly composed by collagen with the scar, with very few sparse myocardial and structure of the scar could be significantly different in other cardiomyopathies. For example, in some areas of hypertrophic cardiomyopathies, but also, for example, in patients with inflammatory cardiomyopathies, in which we can have a less dense scar with a combination of collagen and the cells. And in this case, in CT, the conspicuity and the contrast of the scar could be reduced, and this reduction can impact on the capability to detect the scars itself. You can see that in this case, the scar is it's very easy to detect the post-ischemic scar. It is more difficult, but we can see well this scar within the septum with the mid layer in the septum, and you can see that the contrast of these two different scars is different. This one is a post-ischemic scar. This one is a patient with a post-ischemic dilated cardiomyopathy. And it was demonstrated by this paper ratio of different scars with a subendocardial, mesocardial, or subepicardial distribution, or transmural distribution, but also based on the etiology, ischemic cardiomyopathy or non-ischemic cardiomyopathy. You can see that the contrast to noise ratio in patients with ischemic cardiomyopathy it is significantly higher. And so, what impact based on this reduced contrast to noise ratio? It is also the experience of the operator. We have compared here two operators with different experience, and we can smooth our scar. So essentially, in the ischemic scar, the difference is very limited. But when we go on mesocardial, subepicardial scars that are less dense, the readers with the larger experience perform significantly better than the reader with the lower experience, in particular in terms of sensitivity and not in terms of specificity. What can help is a dual energy approach instead of a single energy approach. Can help with the possibility of reconstructed images in a monoenergetic, with a monoenergetic. Has been demonstrated that the monoenergetic reconstruction and the iodine map can improve the contrast to noise ratio of the late enhancement in CT, and so can improve also the sensitivity with a very slight increase in image noise, but with a strong increase in the late enhancement contrast. And moreover, also the opportunity to acquire all the scan without choosing before the scan itself the level of KBP that we want to use, but reconstructing the monoenergetic after very important, because when you have to choose between, for example, 80 kbp, 100 kbp, or 120 kbp, you certainly will have some patients in which the use of 80 kbp will provide an excess in the noise of the image, or the use of 100 kbp can reduce strongly the contrast of the late enhancement, and so essentially the quality of the final quality of the examination is not good. We have speak up until now of late enhancement, so few minutes to speak also of ECV in CT. The basis of the ECV assessment, it is another time that at the equilibrium, the concentration, the relative concentration of the contrast media within the myocardium and within the blood pool, it is only a function of the ratio between the intracellular space and the extracellular space. So if we make an acquisition after 10 or 15 minutes by the administration of the contrast chelates and for the iodine contrast media, the concentration of the contrast media in the myocardium will depend from the ratio between intracellular and extracellular space, and also the concentration in blood pool. And considering that the concentration of the blood pool, the relationship between intracellular and extracellular space in blood pool, it is known in form of hematocrit. Essentially, we can calculate with a simple equation, which is the extracellular volume fraction in the myocardium. It has been in CMR, it is very stable and more useful than the simple native T1, also because it does not change in different settings, in different scanner, in different conditions, and also because it is very informative, both from the diagnostic point of view, but also from the prognostic point of view. We know from the study that the normal ECV range between 20 and 26%, and we can be in elite athletes, and instead we have a pathological increase of DCV in different conditions from diffuse fibrosis, that it is something that it is strongly correlated to the risk of occurrence of ventricular arrhythmias, in the focal fibrosis, in the infarction, the amyloidosis, and all the diseases. So this is an example of an athlete patient with a reduction of DCV. We know that the stronger increase of the ECV, it is observed in the patient with amyloidosis, in which we have a diffuse and strong increase of DCV that is correlated also with the kind of amyloidosis, and this is strongly correlated with prognosis. So it is both diagnostic and prognostic, as both a diagnostic and prognostic value. The diffuse fibrosis was demonstrated in different settings, both in the hypertrophic and dilated phenotypes. Obviously, we can observe also the strong increase in the ischemic cardiomyopathies, with also the capability to provide a characterization of the enhancement, but using only the ECV assessment. How we can obtain so an ECV map in CT? What we use on conventional scanner since different years is essentially to acquire a non-contrast phase and a late phase after 10 minutes from the administration of the contrast media. And we have an elastic registration between these two different scans. And applying this kind of formula, we can obtain this map of ECV in CT. It has been demonstrated that independently by the map, we can measure with a simple ROI the ounce field unit in the myocardium and in the blood pool before and after before and after the administration of the contrast media, and applying this formula, we can calculate the ECV in CT, and a very good correlation in different settings with the ECV measured in CMR that we can consider up to now the reference standard. We have already said that the ECV could be also more informative than the native and the post-contrast T1, but I don't want to lose time on this. So you can see that you can simply calculate the ECV, for example, in the interventricular septum, just placing some ROI in the interventricular septum in the blood pool and obtaining an ECV that it is strongly correlated with CMR. Where we can apply the ECV and the LG in different settings. First of all, we can say that if today, so we can consider the CT more similar to the CMR. We are evolving from a simple non-invasive angiographic scan of the coronary arteries to a tool that provides an assessment of the function of both ventricle, that provides a good capability to detect the focal scars, like these post-ischemic scars in these patients, and also a tool that allows to provide information about with the map approach or with a simple ROI approach. Applying this kind of two added information, we have created these flow chart for the diagnosis in patient presented with acute chest pain in the emergency department, obviously without a clinical and electrocardiographic diagnosis of myocardial infarction. And what you can see is that using a triple layer approach, assessing first of all the angiographic scan, after that the presence of myocardial skull and the pattern of the myocardial skull, and finally in this single examination calculating the ECV and provide further information using the ECB itself, we can differentiate different kind of diagnosis in this patient. Obviously, the most most frequent the myocarditis and the NOCA, and obviously the ischemic, differentiate in this patient different diagnosis that allows to increase a lot the diagnostic rate of the CT performed in the acute setting and performed in the emergency department. Or also a simple coronary CTA in the emergency department. In most of cases, we have a negative results. In this specific patient, we have a negative results. For example, in the Romicat, 50% of patients has a negative results. But considering that in this study and in our use of the CT, the emergency department, most of this troponin, an increase of troponin, we are simply obscuring part of the assessment. So switching on the lights on the myocarditis, and you can see that we can recognize obviously patients with myocarditis, but also other causes that are more rare but that can be present. Moreover, we can provide also interesting information in patients that at the coronary CTA performed in the emergency department have results for the arteries, and in this patient, having also the information about the myocardium allows to improve the prognostic evaluation of the patient, and also to identify the culprit lesion and to decide the more personalized and suitable approach. You can see here 3 different patients with 3 different situations. Another field in which it was applied, and it seems really interesting, is in the field of patients with aortic stenosis that are candidates to performing TAVI. We know very well that in this patient we can have amyloidosis, but we can have also a slightly increase of the ECB that it is related to the fibrotic remodeling of the myocardium due to the pressure overload that leads, and differentiating patients with a lower ECB and with an higher ECB provides important information in the prognosis and an important prediction of the outcome of the patient after TAVI. And we have newest results in this setting that are also more important, that convince us that probably in the future some patients with a significant increase of ECB have to be treated in a different way and not with TAVI. Obviously, the photon counting detectors. The photon counting detectors allow to improve improve a lot the image quality that we have seen until now in this presentation, both in the LGE, but in particular in the end of very high quality assessment of the ECB or the left contrast resolution that allows to have a panoramic assessment, and that allows to have an assessment of the ECB that essentially provides us all the information that we need, combining the information of the normal enhancement. So producing this kind of maps that are essentially based on a iodine map obtained with a photon counting detector CT, we can have all the information about the scar, the dense scar, the border zone, and also about the fibrotic remodeling, diffuse fibrotic remodeling of the remote myocardium. And you can see this video that it is very impressive. That is the video published by Radiology 1 year ago in this paper, in which they applied the diagnosis of patients with dilated cardiomyopathy. Obviously, the use of ECB in CT allows to be quicker to study. Also is used for those in patients with cardiac devices. I will jump this clinical case because I want to leave time for the discussion. Just the last slide to say that with the photon counting, probably in the future we have the possibility to open the window not only on the imaging of diffuse and focal fibrosis on CT, but also on the imaging of edema. I think that this is the last slide, and we can say that we need to improve the image quality, but essentially the future of tissue characterization in CT is today, now. Thank you very much.
So thank you very much, Antonio. It was a fantastic overview, and also showing how much you were working on this topic with your many publications. So perhaps I start right away with a question regarding the optimal timing. Some people say there is a difference in timing, in optimal timing for late enhancement CT versus ECV quantification, and what is the best trade-off in your mind?
In your mind, the best trade-off remains 7 minutes, because it is the time in which we have the best contrast to noise ratio for the late enhancement. And for what regarding the CV, it is demonstrated that essentially you don't have significant differences going from 5 minutes up to 15 minutes. So considering these two information, I think that the best combination is 7 minutes. Another point that we can highlight is that probably it is useful to stay shorter in patients with non-ischemic cardiomyopathies. So usually I stay up to 6-7 minutes in patients, for example, with myocarditis, with hypertrophic cardiomyopathy, with amyloidosis, and so on, and to use a longer timing, 10-12 minutes in patients with ischemic cardiomyopathies, because in this way you have a reduction of the attenuation of the blood pool. And so for the subendocardial skull, it is better.
Okay. Another question from my side. This paper that you published in Radiology about the acute chest pain patients is really amazing. Now, just between two of us, we are alone. You can tell me the truth. So how realistic is such an approach in clinical routine? I mean, as we all know, cardiac imaging is not so easy. It is much more complex in the emergency setting, not only psychologically, but also the patients. We have higher heart rates, we have more, motion issues, nervous patients, compliance is reduced, perhaps the technologist is also stressed, the technician is also not in the perfect shape. So everything is more difficult, in the emergency setting. So now having such a flow chart, which is really intuitively, of course, makes fully sense. So you check for relevant coronary artery disease, and when this is not there, you go on for late enhancement, and you look also on motion, regional motion, wall motion abnormalities. So what is your opinion about, are you already there? Are you able to include this in clinical routine, or is this just a concept for the near future? How do you handle that?
Yes, thank you, Artem. We are already there for a single reason, because it is so difficult for us to have sufficient slots for CMR for this patient, that we are strongly pushed to solve the diagnosis directly in the emergency department at the moment of the coronary CT. So it is more easy to develop this kind of approach in the emergency department that provide to the clinician sufficient slots for patient that has negative CTA, and so they say to us, obviously, and it is absolutely correct, I need to make a CMR in 3, 4, 5 days. Okay, so this is the reason. But obviously, what it is very important to implement this approach in the emergency department is essentially the experience of the radiologist or of the imager, anyway. Because absolutely it is a more difficult setting in the emergency department, but I think that it is a more difficult setting, particularly for the coronary arteries, because on the myocardial side, if the protocol is standardized and well implemented, the heart rate, the breathing of the patient has a lower impact than on the coronary arteries. What it is very important is it is impossible in obese patients. Absolutely. So in really obese patients, in patients with a BMI larger than 35, 36, absolutely I exclude to perform the delayed enhancement, in particular in the emergency department. But in the other patient, what it is important is the experience of the operator. In my groups, I have some operators with a very good experience that does not have any problem to use in the clinical routine this approach. Obviously, I have some younger colleagues that has some difficulty, but it is only the experience, in my opinion. And obviously the quality of the scanner, because not the quality of the scanner in terms of number of slices or velocity of rotation, but the quality of the scanner in terms of quality of the detectors. And so obviously a new scanner, it could be also a 64 slice scanner, but with performance detector, and also the quality of the iterative reconstruction system.
Mm-hmm. Okay, thank you very much. Very interesting, very interesting. It's also interesting to see that sometimes, shortage of slots leads to innovation.
Yes,
and,
for us, the CT is strongly easier than the CMR. Because,
of course. Yeah, we have this issue in the emergency department where we have these patients, and then they get often CT for ruling out PE, a pulmonary embolism, and then 1 or 2 days later, the same patient should get a CT for ruling out CAD, because the troponin is a little bit higher. They don't believe in CAD, but they want to rule it out because they think it's a perimyocarditis. But since troponin is a little bit elevated and the preter's probability is not so high, they don't want to go for a cath, for catheter angiography. They say, look, let's rule out CAD with CT, and then at some point we get an MR, or we go without MR and have the diagnosis perimyocarditis. And this is always when I think, it would have been optimal to have your protocol in our emergency department. We do a CT, and we can also in the same time rule out PE or aortic dissection whatsoever. And when there is nothing at the coronaries, wait 5 to 7 minutes, do the late enhancement scan, and look if you can detect or ruling out. I don't know if this is possible, but at least rule in perimyocarditis.
Yes, really perimyocarditis, and also a lot of unexpected diagnosis. We have now we have more than 300 patients that have studied with this approach in the emergency department, and you find everything. Patient with amyloidosis, without story of amyloidosis, that have the first clinical sign with an arrhythmia, so with a syncope or with chest pain, they arrive in the emergency department. Patient with an unexpected hypertrophic cardiomyopathy, 2 patients with cardiac metastasis, everything. Essentially, you switch on the light on something that otherwise require a lot of clinical observation, added examination, and so on.
Okay. So thank you very much. I don't see questions in the chat. I think it's now 1:51, so we are slightly over time already. So I want to thank you again for your fantastic insight into this important topic of late enhancement and ECV quantification topic with CT. It was fantastic that you shared your enormous experience with that topic with us. Thanks for the large audience to participate in our webinar. I want to announce the next webinar of this Grand Round series, which will take place in April 18th, same time, 1 p.m. about fully CMR-guided electrophysiological interventional ablation procedure. Believe it or not, it's clinical routine now. So thanks again to everybody and have a nice day. Bye-bye.
Thank you.
Thank you.
Bye-bye. Thank you for the invitation. Bye.